My topic of today's discussion lecture is chest X-ray basics, right? So, have you seen any X-ray? Chest X-ray. Have you seen? Right? So you don't know how to approach chest X-ray film, right? You don't know. So that's why you have to learn the basics of chest X-ray. What are the views of chest X-ray? How the chest X-ray is taken? Is it in correct posture, or is it rotated, or and many other things. So points to remember before reading a chest X-ray. That means, so very frequently it has been observed that the X-ray film is being misplaced, right? So this is very common error. And the name of the, so তুই একটা চেস্ট এক্সরে দেখছিস, হয়তো অন্য কোনো পেশেন্টের, খেয়াল করলি না, নেক্সট পেশেন্টের এক্সরে তোকে দেওয়া হলো, রাইট? সো very important thing is, first you have to check the details of patient that is written in the chest X-ray, whether the name is right, whether the age and sex is right. Next thing is, what is the right side and what is the left side of the X-ray? That is mentioned over here, L or R, right? So that is a marker. Next important point is whether the X-ray has been taken in PA view, that means posterior anterior view. What are the different views of chest X-ray? PA, AP, that means posterior anterior, anterior posterior, lateral decubitus, right? So these are an oblique one. So these are the common views. So most common one is PA, posterior anterior, right? Followed by AP, anterior posterior. So that is written in chest X-ray. And in my next slide, definitely I will describe how to differentiate between PA view, AP view, and lateral decubitus. Okay. So next one is whether the film has been taken during the full inspiration or during the full expiration. Whether the film is in central in position or it is rotated. And lastly, whether the exposure is correct. That means the X-ray is not overexposed or underexposed. So these are the checklist you have to check, right? So next one is differentiate between PA view and AP view. So PA, that means posterior anterior. So the X-ray beam is coming from the posterior part, right? In case of PA view, the patient is standing, right, erect posture, and the film of the X-ray film is adhered to his chest, and the X-ray beam, the machine from where the X-ray beam is coming, that is placed at least 6 feet from the patient. So this is the minimum distance, 6 feet. So the beam is coming from the posterior aspect of the patient. So that is why this is called as PA, the posterior anterior view. And if we discuss about the anterior posterior, so that means the beam is coming from the anterior view. In that case, in anterior posterior view, the detector and the patient placement, the distance between the beam and the patient is less than that of the PA view, right? So how to differentiate between whether this is a PA view or this is a AP view? Most commonly it is written over there at the X-ray film, but now lekha thakte pare. So just by seeing the X-ray, you have to determine whether this is a PA or this is a AP. So heart is placed anteriorly, right? So if the beam is coming from the anterior part, then the cardiac border will be enlarged. This is the most important point. So in case of AP view, the cardiac shadow is enlarged. Whether the PA view, the cardiac shadow is normal, right? And in case of AP view, the ribs are at the parallel position. just like this, just like these lines, ribs. But in PA view, the ribs are not parallel, but it's concave. So just like that. Second point. And third point is the clavicle. The position of clavicle is very important, whether it is in case of PA view or in case of AP view. And scapula, right? So in case of PA view, the correct position is this one. The patient is facing upward and the chin is raised, and the superior aspect of the receptor is 5 centimeter above the shoulder joint. And most importantly, shoulder is rotated anteriorly, because the scapula shadow should not be superimposed. So to retract the scapula, the shoulder should be rotated anteriorly, right? So this is a PA view X-ray, right? Okay, next one is lateral and lateral decubitus. So lateral, that means the beam is coming from the lateral aspect of the chest, right? And lateral decubitus, that means, but mind it, in case of lateral view, the patient should be erect. Patient should be in standing position, not lie down, just like the PA view, right? So in case of lateral, just the difference between the PA and lateral is the beam is coming from the lateral aspect, right? And the hands should be raised. And what is the lateral decubitus? So lateral decubitus is, so decubitus, that means, decubitus means patient's choice, that means patient is in lie down position. Patient is in lie down position and the beam is coming from the lateral side, and most importantly, in case of lateral decubitus view, the shadow of the bed is visible. আমি পরের এক্সরেতে দেখাবো কোন শ্যাডোটা বোঝা যাচ্ছে। The shadow of the bed where the patient is lied down is visible, right? So PA view is the most ideal position, PA view, right? But in case of intubated patients or in those kind of patients who cannot able to stand, who are critically ill, then you have to do X-ray, urgent basis. Then you cannot ask the patient to stand, right? So in that case, AP view may be ideal. ঠিক আছে? And what is the utility of doing a lateral view? So lateral view actually demonstrate the hidden areas. That means those areas that cannot be delineated by the PA view, the retrosternal, retrocardiac and the diaphragmatic areas. So these three areas can be delineated by doing a lateral view. Okay, and the smallest amount of pleural effusion and pneumothorax also can be visible by the lateral and lateral decubitus view. So these are the 4 views, right? So this one is, this is PA view because hard shadow is normal, okay? And look at the ribs. These are the ribs. So ribs are the concaves, right? And this is a AP view. So AP view, the cardiac shadow is wider and the ribs are more or less parallel. Right? PA view the ribs are concave and in this view ribs are parallel. So this is lateral, not lateral decubitus. This is lateral decubitus because this is the shadow of the bed. This is the shadow of the bed. This is lateral decubitus. This is lateral view. So in lateral view, this is the diaphragm, right diaphragm, and this is the left diaphragm. And the retrosternal and retrocardiac areas are visible. This is very important. So this is Can you appreciate that this arch? Can you appreciate? This is arch of aorta. This is not visible in PA view. And this tube, here lies trachea and esophagus, right? And this is the cardiac shadow, cardiac border, okay? So now, whether the fill is taken during full inspiration or full expiration. So in full expiration, lung volume will be normal or increased, right? So lung volume, first point, lung volume is normal or increased. Now whether in expiratory shadow, expiratory fill, the lung volume will be reduced. This is the most important differentiating point between inspiratory and expiratory fill. And the diaphragm will be lowered down during inspiratory phase, and diaphragm is higher up position during the expiratory phase. So in expiratory film, the chest shadow looks like smaller one. So this is the important point, expiratory film. So to detect small amount of pneumothorax, you should do expiratory film. This is the one and only utility of doing an expiratory film. And now regarding the exposure. So if the patient, the chest X-ray film is normally exposed or adequately exposed, then the vertebra are just visible. So this is the vertebrae, right? So this is just visible. The border of the vertebrae are just visible. Whether if this is overexposed, this is an overexposed film, the lung shadow are more hyperlucent or more black, right? And the shadow of the vertebra are more white or more visible. So this is the differentiating point. If you suspect any pathology in your vertebra or bony structure, then only you should order an overexposed film. But in overexposed film, the lung parenchyma, you cannot delineate any pathological change in lung parenchyma because it is not clearly visible. And this is underexposure. The shadow of the vertebra is not visible and this is more hypolucent. That means more white, right? So this is exposure. And next one is rotation. Whether the patient position is correct or the patient is rotated, right? হয়তো পেশেন্টকে বলা হয়েছে যে স্ক্যাপুলা অ্যান্টিরিয়রলি শোল্ডার অ্যান্টিরিয়রলি রিট্রাক্ট করে দাঁড়াতে, পেশেন্ট দাঁড়াতে পারলো না আর পেশেন্ট টিল্ট হয়ে গেল, তখন কিভাবে বুঝতে পারবি? বিকজ দিস ইজ ভেরি ইম্পর্টেন্ট, বিকজ you should assess the position of the trachea first. So if the patient is rotated, then the trachea will automatically be one-sided, right? So suppose the patient is in right-sided rotated, the trachea will also be shifted. মানে কিভাবে দেখবি ট্র্যাকিয়াটাকে? Trachea shifts to the right side. But this is wrong, right? So originally the trachea is central, but যখন patient rotated হচ্ছে তো trachea এর পজিশনও চেঞ্জ হয়ে যাচ্ছে. So this is very important. Rotation you should assess. So how to assess rotation? This is the spinous process. এই যে হোয়াইট ট্রায়াঙ্গেল শেপের, ঠিক আছে, দেখতে পাচ্ছিস ভার্টিব্রার মধ্যে একটা হোয়াইট একটা ট্রায়াঙ্গেল শেপের, দিস ইজ দ্য স্পাইনাস প্রসেস অফ ভার্টিব্রা. সো if you track down the spinous process, these are the spinous processes. Then these are the end of two clavicles, right and left. So the distance between the spinous process and the clavicle will be same, both sided. Clear? So spinous process and clavicle distance in right side is equals to spinous process and left sided clavicle distance, end of clavicle distance. So that is needed to determine whether the patient is rotated or not. That next একটা দেখাচ্ছি, এখানে patient rotated or not, এক্সরেটাতে। So this is spinous process, and the distance from the spinous process to the right end of clavicle is more than that of the left sided clavicle. So that means patient is rotated. So you cannot comment in this X-ray whether the trachea is in central position. Right? Because trachea is also deviated because of the rotation. Now, how to read chest X-ray? This is important. So the most important approach to read a chest X-ray is from outside to outward to inward position. Outward, that means বাইরে থেকে ভেতর দিকে আসতে হবে। বাইরে কি আছে? বাইরে কি আছে? Right, skeletal structures, soft tissue, so that you cannot miss any of the point. Skeletal structure, soft tissue. Skeletal structure, that means which skeletal structures is visible? First is ribs are visible. Or next key, scapula, clavicle, acromion process, shoulder joint. These are the visible. These are visible skeletal structures. So প্রত্যেকটা point কে করতে হবে। Next one is soft tissue. So soft tissues are visible. That means if any soft tissue lesions are there, if any soft tissue tumors like neurofibromatosis is there or not. Most importantly, খুব ইম্পর্টেন্ট যেটা সেটা হচ্ছে টু অ্যাসেস দ্য ব্রেস্ট টিস্যু, ব্রেস্ট শ্যাডো। সো ব্রেস্ট শ্যাডো ইজ ভিজিবল অর নট bilaterally. This is important. And whether there are more black shadows at the soft tissue, at the outside the chest X-ray, outside the lung parenchyma, if there is any black shadows are there, so that indicates there is air inside the tissue. Air inside the tissue. That means maybe this is a case of surgical or subcutaneous emphysema. ঠিক আছে? So that means this is first one is skeletal structures, soft tissue structures, then inside, then trachea. First, central in position or not, trachea is central or deviated. ঠিক আছে? Next one, parenchyma structures. Lung parenchyma is visible bilaterally, whether is it any opacities or any consolidation or any other pleural effusion or pneumothorax is there or not. Assess the diaphragm. Next, assess the bilateral diaphragm, whether both the diaphragm shape is maintained or not, and gas under diaphragm is present or not. ঠিক আছে? These are the structures. So we all know that the right lung has 3 lobes, right? 2 fissures, one, that means horizontal and oblique fissure, and left lung 1 fissure, that means oblique fissure. So normally horizontal fissure, oblique fissure is not visible, but sometimes horizontal fissure may be visible if there is any fluid along the horizontal fissure, that means fissural effusion or any consolidation or any fibrosis over the fissure line, then only the horizontal fissure is visible, but the oblique fissure is never visible. So this is the trachea, these are the parenchymas, this is the horizontal fissure, this is the oblique fissure, and this is the cardiac shadow. This is the cardiac shadow. These are the 2 diaphragms, right, hemidiaphragms, right and left, and what is this? This is fundic gas shadow, right? This is fundic gas shadow. And these are the 2 hilums. This is hilum and this is another hilum. Okay. So these are the 2 angles, costophrenic and cardiophrenic angles. So this is costophrenic angle. These are the cardiophrenic angles. Next, bone and soft tissue. Any abnormality in the first X-ray? Yes, clavicle fracture is there. Lateral end of the clavicle and displaced. This one, shoulder joint displacement. This one, it is visible now, probably. just this is the second rib, right? Continuity of the rib is broken. Visible এটা? দেখতে পাচ্ছিস? এই যে ব্রেকেজ লাইন এটা একটা অ্যান্টিরিয়ালে চলে গেছে একটা পোস্টেরিয়ালে চলে গেছে। Similarly this one, continuity of the rib is broken. That means rib fracture. Next, this is kyphoscoliosis, and this is যেটা আমি একটু আগে বলছিলাম সফট টিস্যু ইম্পর্টেন্ট কেন দেখতে পাচ্ছিস এখানে কিছু ওপাসিটিস আছে হ্যাঁ ওপাসিটিস these are the soft tissue opacities. This is neurofibromatosis neurofibromas এগুলো হচ্ছে neurofibromatosis shadow, and this is black shadows, multiple black shadows at the soft tissue area. Surgical emphysema, একটু আগে বললাম না subcutaneous emphysema, air trapped in the subcutaneous space. And this is any abnormality in this x-ray? এই x-ray তে কোনো abnormality আছে? This is the right breast shadow but left breast shadow is absent. এখানে কোনো breast shadow আছে? Probably the patient is a known case of breast CA and post mastectomy status, right? So this is important. Gas under diaphragm. So normally gas under diaphragm is present at below the right diaphragm because of the fundic gas shadow, right? Sorry, and left diaphragm. And whether if the gas shadow is present below the both diaphragm, right and left diaphragm, that indicates pneumoperitoneum. That means the air leaking from the peritoneum and reaches below the two diaphragm. Pneumoperitoneum, right? So this is pneumoperitoneum below the right and below the left one, and this is pneumoperitoneum. Is it? This is pneumoperitoneum. Very important point is free gas under diaphragm. This is pneumoperitoneum. This is a free gas. But this is not a free gas. This is colon. This is colon shadow. These are the hostrations. Is it? Egulo hostrations to. So this is called Chilaiditi syndrome. Chilaiditi syndrome. ঠিক আছে? And this is called Neclerio V sign. That means the sharpened border of the left or right cardiophrenic angle. So just like a V separate structure. তাই তো? এই যে clear? So this is a sign of any idea? Pneumomediastinum. That means air is trapped inside the mediastinum. Next, diaphragm. So both the diaphragm are C-shaped, right? And normally, and you can definitely evaluate both the diaphragm in PA view, then and AP view also, then the lateral view. So you have to calculate the diaphragmatic index, whether the diaphragm is correctly positioned or not. That means কি হয় basically you have read about emphysema, right? Or COPD পড়েছিস? COPD পড়েছিলাম তো, or emphysema. So in case of emphysema the lung volume will be increased. So because of the increased lung volume, the diaphragm will become flat. This is the contour, C-shaped. But in case of emphysema or COPD, the contour of the diaphragm is lost and the diaphragm will become flat. So how to assess whether the diaphragm is flat or the diaphragm is normal? So there is an index, this is called diaphragmatic index. So you have to measure You have to draw a line between the two costophonic and cardiophonic angles. Draw a line between the costophonic and cardiophonic angles. This is the line. And measure the distance from the highest point of the diaphragm. So if this is the diaphragm, so this is the highest point, right? This is the line joining the two end of diaphragm, and distance from the highest point and the line is measured. This is called diaphragmatic index. So if the diaphragmatic index is low, then the diaphragm is flat, and if it is normal, then the diaphragm is in normal position. So this is normal diaphragm, but this is flat diaphragm because the diaphragmatic index is low. And this is any abnormality in this X-ray? Yes, this is a case of diaphragmatic hernia because this is the colon shadow. These are the hostessions, and the colon enters through the diaphragm, reaches to the chest wall, right? Thorax. So this is left-sided diaphragmatic hernia. So which sided diaphragmatic hernia is more common, left or right? Left or right? Left. Why not right? Yes, because liver is there. So left-sided diaphragmatic hernia is more common. Another, this is called diaphragmatic hump. This is a deformity, congenital deformity, but problem kichu patient er hoy na. This is a findings, right? So diaphragmatic hump. Next, costo and cardiophonic angles. So these are the costophonic angles and these are the cardiophonic angle. Why this is important? Costophonic angles and cardiophonic angles. Blunting of CP angles. That means you are dealing with a case of pleural effusion, right? So this is the primary X-ray finding. Blunting of both the CP angles, costophonic angles. So how many amount of fluid should be present to blunt the costophonic angles? আগের ইয়ারে ক্লাসে পড়িয়েছিলাম pleural effusion 175 to 200 ml is sufficient to blunt the CP angles. So these are the blunting of CP angles, right? So this is bilateral pleural effusion and this is, so how to explain pleural effusion in X-ray? কেউ একজন বল, এই এক্সরেটাকে একটু ডেসক্রাইব কর, কিভাবে ডেসক্রাইব করবি? কেউ একজন বল, মেনশন করার দরকার নেই, জাস্ট পিএ ভিউ যেটা বললি, পিএ ভিউ আর স্কায়াগ্রাম অফ এক্স। যদি তোকে জিজ্ঞেস করে whether this is rotated or not, whether this is over exposed or not, তখন মেনশন করবি, ঠিক আছে? বাট জাস্ট তারপর বল। দরকার নেই, তুই জাস্ট পজিটিভ ফাইন্ডিংটা কি আছে বল। One is blunting of CP angle, blunting of left-sided CP angle is there. ঠিক, এক নম্বর। সেকেন্ড, both left-sided costophonic angle is blunt. First point. Second, সেটা পরে কি হবে, এটা কি শ্যাডো, এটা হাইপোলুসেন্ট আর হাইপারলুসেন্ট? হাইপো, তাই তো, hypolucent shadow. Blunting of the CP angle and hypolucent shadow, and the upper border of the concavity is directed towards the axilla. ঠিক তো, এই যে this is the upper border of the concavity towards the axilla. So this is called meniscus sign. This is a sign of free pleural effusion. Free pleural effusion. That means the pleural effusion is free, that is not loculated one. Okay. So this is, এটা বল। difference. So this is also the CP angle is blunt. CP angle is blunt, but there is no meniscus. This is D-shaped effusion. The shape is like D, right? So this is loculated pleural effusion, and this is এটা কি? Hydropneumothorax. So this is an horizontal air fluid level. You have to describe that in that way. There is an horizontal air fluid level at the right side of the chest, suggesting this is a case of right hydropneumothorax. And this is also hydropneumothorax, right? There is an air fluid level, just like that. Why this is abscess and why this is hydropneumothorax? One, very good. This is a thick wall. The air fluid level inside the thick wall cavity is there, and most importantly, the air fluid level, horizontal air fluid level in previous X-ray is just parallel to the diaphragm. That means through and through, just parallel to diaphragm. Diaphragm যত দূরে গেছে তত দূরে তোর এই শ্যাডোটা আছে. That means this is a case of hydropneumothorax. Whether in that case the air fluid level is inside the cavity and this is not through and through. So this is a case of lung abscess. Clear? Just I have mentioned about the pleural effusion. This is a meniscus sign and this is free pleural effusion. This is loculated pleural effusion and this is, so difference between this picture and this picture, first and third picture. Look at the position of the trachea. So in first picture the trachea is more or less central, right? And in this picture the trachea is deviated and there is pleural effusion. So this is massive pleural effusion. So if the effusion shadow reaches up to the second intercostal space, that means this is a massive pleural effusion, right? And the trachea is deviated. So this is a case of massive pleural effusion. So this is definitely, I have already mentioned about that, this is a hydropneumothorax. And this is fissure, horizontal fissure. And there is effusion at the level of horizontal fissure. যেটা আমি বললাম না, horizontal fissure is not visible, but if there is effusion or any fibrosis over there, then only the horizontal fissure is visible. So that means in this X-ray the horizontal fissure is having effusion. So it is visible and this is called fissural fissure or phantom tumor. Phantom tumor. So this is the earliest sign in heart failure. In heart failure, the effusion, the pleural fluid accumulates at the level of fissure, then at the level of two angles. So this is a case of phantom tumor. And this is right unilateral or bilateral pleural effusion. This is a case of bilateral pleural effusion because left sided CP angle is also blunt, but definitely right side has more fluid than left side. And any other abnormality, any other findings? Yes, this is a pacemaker and the cardiothoracic ratio is increased and there is bilateral pleural effusion. That means the pleural effusion is probably due to heart failure. Now the cardiac chambers. So this is the left atrial shadow, this is the left ventricle, this is the right ventricle and this is the right atrium. So during the reading of the chest X-ray, you have to assess whether the cardiac shadow is enlarged or not, whether the patient is having cardiomegaly or not. So how to assess whether the patient is having cardiomegaly or not? By assessing the CTR, cardiothoracic ratio. So you have to draw a line through the spinous process. This is the line through the spinous process. Then you have to measure the right ventricular diameter, that means from that line to the right ventricle. This is A and this is the diameter of left ventricle. From that horizontal, from the line to that of the left ventricle. So this is A and this is B. And next you have to measure the complete thorax volume from one-sided CP to another sided CP angle. So this is the total thorax volume, and this A and B is the cardiac shadow volume. So A plus B by total D or C, you can mention A plus B divided by C. So this is the cardiothoracic ratio. ठीक है? And the normal is less than equals to 1:2. But if that is more than 1:2, then the cardiothoracic ratio is increased. So assess the cardiothoracic ratio. Draw a line through the spinous process. This is the spinous process, and right heart chamber, left heart shadow. So this is the right and this is the left. So left sided ventricle is more, the shadow of the left sided heart is more. So the ratio A plus B divided by C is definitely suggesting the patient is having cardiomegaly, increased cardiothoracic ratio. Another example, increased cardiothoracic ratio, but this is not only cardiomegaly. This is a case of pericardial effusion, water bottle shaped heart, right? That shape of the heart. So this is just like a water bottle shaped heart. So this is pericardial effusion. Next, pleura. So first, before discussing pleura, you have to assess the costo and cardiophrenic angle. This is important. And next, trace the pleural reflections. So these are the pleural reflections: diaphragmatic pleura and costal and mediastinal pleura. Any abnormality over there or not? So this is, this is a kind of hypolucent area, right? Non-continuous hypolucent area. This is pleural calcification. Pleural calcification, most commonly seen in asbestosis. And this is, এটা কি? এটা তোদের বলা উচিত। This is pneumothorax, right-sided pneumothorax. This is the visceral pleural line. This is the visceral pleural line, and there is hyperlucency at the right side of the thorax. There is visceral pleural line is visible, and this is a collapsed lung. This is a collapsed lung. Pneumothorax চিনতে অসুবিধা হবে? Pneumothorax so very easy to detect. Pneumothorax. This is a case of pneumothorax. So pneumothorax এর দুটো পয়েন্ট খুব ইম্পর্টেন্ট। One is hyperlucent area. এই যে this is a hyperlucent area. দেখ কম্পেয়ার কর এই সাইডটার সঙ্গে। লেফট সাইডের যে এরিয়াগুলো আছে সেখানে তো ব্রঙ্কোভাস্কুলার মার্কিং আর প্রমিনেন্ট। That means there are multiple white and black shadows. But in right side, this is devoid of any bronchovascular marking, and the area is typically hyperlucent. This is the first point. Second one is visceral pleural line. So this is the visceral pleural lining. ঠিক আছে? So these are the most important points to detect whether the patient is having pneumothorax or not. And this is another X-ray of this patient. Any abnormality? This patient. So this is chest drain, intercostal tube drain. দেখ এখানে pneumothorax রিজলভ করে গেছে, এখানে pneumothorax নেই। And chest tube in situ. Clear? These are the congenital heart disease radiology. এগুলো pediatrics এ আশা করি পড়েছিস, পড়ানো হয়েছে pediatrics এ। So this is boot shaped heart, or that is tetralogy of Fallot. The left ventricle is enlarged. This is agon string appearance or TGA, and this is important. What is this? This X-ray is very important. Very commonly you can find this type of X-ray in your IPD round or ICU round. First, the cardiothoracic ratio is increased definitely, and there are opacities around the both hilum, both hilar area are congested. That the এই যে যেগুলো hilar area গুলো আছে সেগুলো তো congested, but এই congestion is not spreaded to the periphery of the chest. Periphery of the chest is almost clear. The opacities are just around the hilum. So this is called Batwing appearance or typically pulmonary edema. So this is very important. Next, hilum. So you all know that both hilum contains multiple vessels, bronchial and pulmonary artery, vein and lymph nodes, lymphatics, right? So both the hilum looks like the inverted V shaped. Okay, but you have to assess, মানে most commonly আমাদের hilum দেখার importance টা কি? If there is hilar lymphadenopathy or not. Hilar lymph nodes are most commonly enlarged in pathological diseases, right? Like tuberculosis, like silicosis, and in case of different malignancies as well. So you have to assess the hilar shadow and if there is hilar lymphadenopathy or not. ঠিক আছে? So this is normal hilum. These are the normal hilum. Just the hilar vessels are visible. No lymphadenopathy is visible. But this is enlarged hilar shadow. Clear? Difference টা বুঝতে পারছিস? This is normal and this is enlarged hilar shadow. So these are bilateral hilar prominence, probably due to hilar lymphadenopathy. So bilateral hilar lymphadenopathy যদি থাকে কোনো পেশেন্টের, তাহলে কি সাসপেক্ট করবি, কোন ডিজিজ সাসপেক্ট করতে পারবি? টিবি ডেফিনেটলি, দেন সিলিকোসিস ডেফিনেটলি, and sarcoidosis. Very important differentiating point. So যদি তোকে কোনো এক্সরে দেখিয়ে বলে, ধর এক্সামিনার জিজ্ঞেস করলো যে কি কি ডিডি, তুই বলবি টিবি, সিলিকোসিস and sarcoidosis. And this is also important. এটা কি? This shadow. This is a normal chest X-ray and this is not normal. What is abnormality? What is the abnormality? This is a shadow encroaching the right hilum, right? এই শ্যাডোটা দেখতে পাচ্ছিস তো, রাইট সাইডে আছে শ্যাডোটা। This is right, not right, this is anterior mediastinal mass, most likely teratoma. Why? Because this is the mediastinum. This is the mediastinum, and the mediastinum is enlarged first, and second is the shadow is overlapping the hilum. The hilum is not visible. Right sided hilum is not visible, but you can see small white dots. এই যে dots গুলো দেখতে পাচ্ছিস? These dots, these are hilar vessels. So if you can see, so this is a mass, definitely this is a mass. Whether this mass is originating from the hilum, that means this is a lung mass or this is a mediastinal mass. You have to differentiate. If the mass is originating from the hilum or lung itself, then you cannot see the hilar vessels through it. But in this case, the hilar vessels, like these dots are hilar vessels, is visible. So this is mediastinal mass. Okay. So this is called hilum overlay sign. This is called hilum overlay sign. Okay. So pneumothorax, this is a case of pneumothorax. This is the visceral pleural line, left sided pneumothorax, and this is a collapsed lung, like a fist. The lung collapses like a fist towards the hilum. And this is right, there may be the right sided pneumothorax that is resolved now, and there is right sided intercostal tube in situ. And this is also a case of pneumothorax, right? This is pneumothorax. This is pneumothorax and this is also pneumothorax. This is also hyperlucent area. No, this is not a pneumothorax. This is a case of large left-sided bulla. Why? Because look at the border. The pneumothorax border is convex. Whether the border of the bulla is concave like this, and pneumothorax border is convex. So this is case of large bulla and this is a case of pneumothorax. Mediastinum. So mediastinum, you can delineate different, so there are three mediastinums, right? Mediastinal areas you can divide. One is anterior, one is middle and one is posterior. Three mediastinum can be delineated at the lateral X-ray, not at the PA view. And this is a mediastinal mass, huge anterior mediastinal mass, and hilar vessels are prominent. So this is hilum overlay sign and the mass is situated at the anterior mediastinum. And most importantly, যখন describe করবি external কে বা internal কে during your examination, কি X-ray they describe the X-ray. Suppose there is opacity at any area of X-ray or any area of chest. বলবি না যে right middle lobe or right upper lobe. Always mention about zone. Right upper zone, right middle zone, right lower zone, left upper zone, left middle zone and left lower zone. So the zone can be divided by seeing the rib. From the second to fourth, above the second rib, this is upper zone. Second to fourth, this is middle zone, and below fourth, this is lower zone. Always mention about zone, not the lobe. So in case of consolidation or pneumonia itself, so never mention pneumonia in X-ray. Always mention about consolidation, right? So in case of consolidation, there are presence of bronchovascular markings and air shadows, right, inside the opacity. But whether in case of collapse, the shadow is devoid of any bronchovascular marking. So this bronchovascular marking in your consolidation X-ray is called as air bronchogram. Air bronchogram. And in case of collapse, there is no bronchovascular marking is present. And so collapse, that means, so what is the reason of collapse? There may be two types of collapse. One is active and one is passive collapse. So active collapse, that means something pulling the trachea inside. If there is, suppose, any mass or any foreign body obstructing the bronchus, suppose the right upper lobe bronchus is obstructed by a foreign body or by a mass. So there is a negative pressure creating, right, at the right upper lobe bronchus, and that because of that negative pressure, the trachea is pulled down at the right side. But in case of consolidation, the trachea position would be normal. In case of collapse, the trachea is pulled at the collapsed area. That this is a case of right upper lobe collapse. The trachea is pulled. এই যে trachea তো centrally হওয়া উচিত ছিল, এরকম হওয়া উচিত ছিল, but the trachea is pulled to right upper lobe, right sided, and there is opacity, and definitely the fissure is also visible, horizontal fissure. So this is right upper lobe collapse, and this is a triangle shaped opacity at the middle zone. This is right middle lobe collapse, and this is in this case the right diaphragm is not visible. তাই তো right diaphragm তো visible নয়. There is একটা curvilinear shadow আছে throughout the right lower lobe. So this is right lower lobe collapse. So the diaphragm is pulled up, and the right lower lobe is not visible. So this is right lower lobe collapse, and this is whole lung collapse. Right sided lung is not visible, and the trachea is pulled towards the right sided lung. This is right sided whole lung collapse. And this is also right upper lobe collapse. এই যে border of the fissure is visible, and the trachea is pulled down. এই যে trachea দেখতে পাচ্ছি এখান থেকে, এই যে trachea গেছে কোথা থেকে. So this is right upper lobe collapse. So this is এই x-ray কি? Can you describe that x-ray? Can you describe? There is an inhomogeneous opacity at the right middle zone, inhomogeneous opacity with presence of air bronchogram. এই দেখ, these are the air bronchograms. Can you see that? These black shadows, এই যে দেখতে পাচ্ছিস কিছু black shadows আছে over the area of the inhomogeneous opacity. This is called right middle lobe consolidation. Why middle lobe? The fissure is visible, and this is lobar pneumonia, lobar consolidation, because only the only one lobe is affected, not the whole lung. And this is, এটা আগের বার আমি নিউমোনিয়াতে এই এমসিকিউটা দিয়েছিলাম আগের বার ক্লাসে, আগের ইয়ারে তোদের হয়েছিল, কি বলতো এটা? This is bulging fissure sign. The fissure is bulged down. Horizontal fissure is bulged downward, and there is a inhomogeneous opacity at the right upper and middle zone, and the horizontal fissure is bulged down. So this is কোন নিউমোনিয়াতে bulging fissure হয়? Very good, Klebsiella pneumonia. So this is a case of Klebsiella pneumonia, and this is multiple homogeneous opacities over all the areas of right and left lung. So this is a case of bronchopneumonia. There is no lobar predilection, just the opacities are distributed unevenly throughout the bilateral lung field. So this is a case of bronchopneumonia, right? So this is lobar pneumonia and this is bronchopneumonia. Okay, so this is end of my slide. Any query? Any query? যখন ওয়ার্ডে যাবি, যখন তোর ইয়ে হবে প্র্যাকটিক্যাল হবে, বা যখন ওয়ার্ডে যাবি, এমনি ওয়ার্ডে কিন্তু মাঝে মাঝে যাবি, এক্সরে দেখতেই যেতে হবে। এক্সরে দেখা একটা কিন্তু একটা প্র্যাকটিস। এক্সরে কিন্তু এক্সরে স্কিল একদিনে আসবে না। এক্সরে ইসিজি যত দেখবি তত কিন্তু শিখবি। অলওয়েজ ডেসক্রাইব এক্সরে, অলওয়েজ ডেসক্রাইব দ্য এক্সরে। যখন কোনো এক্সরে দেখবি তখন এক্সরে ডেসক্রাইব করতে শিখবি, তবে এক্সরে কিন্তু প্রপারলি বুঝতে পারবি, রাইট?